Good morning. It's still GTV breakfast, and we're going to have a conversation around something that's causing a stir, where we should all be concerned. I don't know if we should call it a health emergency, but over 23,000 people have tested positive for HIV in the first 6 months of this year. That means January to August alone, 23,000 people, and this figure represents 2% of over 948,000 people who undertook this test. That is from January to June. So the big question is, why are we letting our guard down? What are we not doing right? And we are going to have Dr. Stephen Ado, who is the program manager of the National STIs and HIV/AIDS Control Program, and he's joined us at the table for this discussion. Good morning, Dr.
Good morning,
Ado.
and good morning to our viewers.
Pleasure to have you here.
Thanks a lot. And how are you?
I'm all right.
When was the last time you checked your status for HIV?
5 years ago.
The assumption is that you've not been exposed in any way. But if you've been exposed, why have you not checked?
So the big question I want to ask is, why are we letting our guard down? When was the last time you checked your HIV status? Our WhatsApp screen is interactive, and we are interactive on Facebook as well as the Ghana Broadcasting Corporation, and on 055-5561034. So, Dr. Ado, what's causing us to let our guard down? What's happening to us?
Thank you. So the first thing is complacency. All right, we've come through a process. The epidemic has matured. We come to a certain level where things are just as if it's business as usual.
Right.
Not the same as it used to be in the past, where we used to have a lot of people who were ill, who were sick, people who were emaciated, and photos and the pictures of near-death situations was staring the face of Ghanaians, and everybody was agitated. It's similar to when we experienced the pandemic 2 years ago for COVID-19, and people were not certain, they were not sure of how things were going to pan out, they were not sure how people were going to get it. So in the same way, in the 1986, since we found the first case, and then it evolved over a period, things were getting worse, people were falling ill, we didn't have treatment, and so people were alert. Now that in 2003 we got treatment, started putting people on medication, we were not seeing a lot of the AIDS pictures, all right? And because of that, everybody thought that AIDS is gone, HIV is gone. Now, we must separate AIDS from HIV, because AIDS is the disease state, all right? And this is where it's near death. But HIV is like anybody who has been exposed to any infection, and the person may not necessarily show symptoms and signs. The person may be going about their duty normally and all that. And now the situation is worse because we have more people who are on treatment. We used to even wait for people to get a little weaker or meet a certain criteria before putting the people on treatment. But now the moment you are tested, if we got it just yesterday, you will be put on treatment when you feel well. Because of all this, people psychologically think that HIV is no more a problem, number one. They also believe that because we're not seeing very sick people, transmission is not occurring. So if we used to present a certain message for prevention, they are no more relevant. But the statistics show that in actual fact, this number we found will more than double before the year ends.
No way.
I can tell you this, and I wish to state that what is even more worrying to us as a program is that we estimate that there are about 350,000 people who are living with HIV in Ghana. 350 years. Now, these 350,000 are in the general population. We found some of them, including those we tested this first half of the year.
Wow.
There are some 101,500 and more that we don't know, but they are in the community and they are spreading. They are living normal. They are doing the same things, unprotected sex, taking all the risk. So complacency is the first reason. Number two is the environment. You see, because we have a low prevalence, everybody wants to believe and feel to be part of the 98%, okay, who are positive, and therefore look down on potentially those who are negative, and therefore look down on those who are positive. So there's a lot of stigma and discrimination. There's a lot of stigmatizing acts and behavior. Now, which means that the few people who must own up to be managed will also behave that they are negative, and they'll be quiet and spread it. Because if you make me feel bad about it, I will not disclose to you. We've come through a cycle where even people who were positive and were on treatment and were looking good and told people that I'm HIV positive, you are not serious. You are kidding me. You don't want me to have my way. And so if I have to explain myself, and then once you get to know, you change your attitude immediately towards me, there's no way I'll make the effort. So there are a lot of people who they know they are HIV. They are spreading quietly. But worst of all, those who don't know and who are spreading is what we need to be alert about.
Is there, from the survey and the research, is there a particular age bracket that is leading this number?
Yes, usually we've noticed that between the ages of 30 to 40 years is the highest, prevalence. In of this figure, 8% are children, 0 to 14. Okay, the rest are adults. But if you take the adult age bracket from the age of about 30 to 40 is the peak. And even this is reflected in our Sentinel survey when we do the studies among pregnant women. We also realize that the prevalence is high amongst high-risk men.
High-risk men.
High-risk men.
Which people are considered high-risk men?
High-risk men include, first of all, men who have sex with men. And their general prevalence is 18% if you compare to the general public of 2%.
Wow.
18%. So this is like times 9. Right. Then you also have some men who are partners of female sex workers. Female sex worker prevalence is almost 5%, 4.6. That's also high. So once they are positive, they are partners who are males. They are the non-paying partners. They are high risk also. You also have some men who are in male-dominated settings in certain places like the mining areas, Galamsey work and all that. There's a lot of transactional sex in those places, mining industries and all that. In male-dominated settings, like even in the transport business, where you have drivers traveling long distances away from home and all that, they are very vulnerable. All right. Where people inject drugs, you notice that sometimes they mix the drug, with very high risky behavior.
Right.
The use of substances, which removes people's ability to prevent and to be cautious. So all these can be categorized as high risk, men. But we also have the females, high risk females. Those are the female sex workers. The other vulnerable population are the partners of the bisexuals, of people, men who have sex with men. In Ghana, our men who have sex with men profile is that most of them are young, and some of them are bisexual. So whereas they are homosexuals, they have female partners.
And so most of these, so how do we call them bisexuals or homosexuals in this case?
They are bisexual because they are practicing homosexual. They have men, they sleep with men, but they have female partners.
And do their partners, half of the time, the people that you get and the research, do their partners know that they are sleeping with men?
Some of them know, some of them don't know. And the reason is that because we frown on men who have sex with men, they also don't want to be known, all right? So they will hide it, from their partners. Some of them just get female partners or girlfriends just to cover up, because they don't want people to know that they are, sleeping with other men.
Okay. So, Dr. Isi, what's the way forward? We
need to go back to the beginning. If I have to draw for you, at the beginning of every epidemic, there's that buzz. Then over time, there's complacency. But now we have elected to achieve epidemic control in less than 10 years. All right. So we need to reignite the campaign. community. This, what I'm having with you, must be a regular feature now in our country. And almost every morning, every day, every week, we need to talk about HIV. We need to prevent. Now, what is more dangerous is that we have a huge number of people now on treatment.
Okay.
The complacency can lead to people even not taking their medication over time because they feel well. It will create another epidemic, which is the HIV drug resistance epidemic. In other words, very soon when people are not adhering, they are not taking their medications, the drugs will not be effective against the virus again. And then because we are limited with options, they will be transmitting resistant strains. And that is worse. Okay, so like we are experiencing tuberculosis, this can happen in HIV and we have to stop. And that's why we need to support people on treatment, because treatment will ensure suppression and it will ensure it will prevent transmission. This is what we call U is equal to U. If you are on treatment, the viral load is undetectable. So undetectable is untransmissible. And so we must support as many people as possible to be on treatment. It starts with knowing their status.
Okay. Now, talking on treatment, is it readily available? Is it easily accessible? Do you just walk into any facility? Because from a survey we did on Facebook, people wouldn't want to walk into a facility where it's labeled HIV/AIDS for the sake of stigma. So what's happening in that regard?
Yes, so it is available now. We have more than 600 facilities now in the country who are offering antiretroviral therapy, both in public and private sector. Now, when you even go to any service delivery site now in Ghana, you'll be offered a test. But because treatment is not everywhere, then you have to assess treatment in the limited area. So what we are doing is to decentralize the treatment now.
Okay.
We are even decentralizing into ANC settings so that when pregnant women, come to deliver, they are identified positive, they can have access immediately. Okay. We also want to move it to the chief's compounds. We want to move it also to the community now. Very soon, people can pick their medications in pharmacies and some identifiable community centers. But one of the things we've realized is that whilst we are making all these efforts, because of stigma and discrimination, the persons living with HIV are running away. So I'm coming closer to you in the community, but because of the issues of stigma, they don't want to be identified. So they will prefer to travel from Accra to Kumasi, for instance, to take their medication. But we know that cost, of transportation and all that is a barrier to accessing treatment. All right. So if we're able to minimize all the stigma, then people will feel free and accept the service. So we are decentralizing, but we must help those who are recipients of care to access the service. So it's available, it's free. If you have NHIA, you must have antiretroviral therapy free of charge. No one should sell antiretrovirals. If anybody is selling, it's against the law. And it's a barrier, to our efforts. So ART is available, and no one should die from AIDS because of lack of treatment today in Ghana. And nobody should get to the picture, the flyer that you showed, to the 8th stage, just because of lack of access to treatment. Do not walk in the dark. Get to know your status. There are a few people who suspect they may have, but they are not confident. So we are also deploying what we call the self-test.
Okay.
Very soon, you will be able to access test kits in the pharmacy or somewhere and test yourself. If you are reactive, then we confirm for you, so that you don't feel bad before the health worker. But once you are convinced, we'll teach you, we'll direct you, and then you get treatment. So it's available and people should access it.
Going forward, we've had comments like, COVID kills faster than HIV. HIV doesn't exist. It's no longer accidents kill. Are we throwing caution to the wind as a country? Are we being complacent because of recent lifestyles? What's pushing this surge, Doctor?
COVID has never killed people more than HIV. HIV today has killed more people. In fact, this year, the first 6 months, 932 people died in our database. This is people
this is from January
we know.
To August.
Yes, we've documented. Every year we estimate about 11,000 deaths. But let's assume that we don't know them. It includes those who have not come, they don't know their status. But this one I'm talking about, 900. How many people has COVID killed? This period, even Marburg fever. All right, the hemorrhagic fevers. So HIV is still formidable, but the only thing that is happening is that because people have relaxed, they are only deferring the death. In the past, if you had it within 7 years, you go down, or up to 15 years, you go down. But now, because of treatment, you'll be fine for a while. But people take the medication, they relax. So people are just postponing, all right, and the death is occurring. And that is why we find it appropriate at this time to alert the nation, to let people wake up to it, because it's just becoming a silent, killer. And we can do something about it. We're working hard, trying to find options, treatment, even vaccine studies and all that. But the first effort must be from the individual. All of us must first of all think about prevention. Before any ultimate cure comes, let's do the things. Let's go back to the ABCs of prevention. And we need to wage the war amongst the youth.
Which parts of Ghana have we recorded the highest numbers?
Right. So, we used to say that Eastern region was the region with the highest. Now it's changed. We've evolved from Eastern region to Greater Accra, Ashanti, and now it's Bono. In fact, in this study, they were about 4%, Ahafo and Bono. So the United States of Wrong Ahafo, which has now been separated into Bono, Ahafo, and Bono East. We have to pay attention to those regions. But Western region is also one of the regions, and it's coming up. And close to Western region is Western North. They were together, we separated. Yeah. But Greater Accra and Ashanti, because of the population, the numbers are high. We have the highest number of persons living with HIV we had in Ashanti. If you look at the HIV Sentinel survey we conduct every year among pregnant women, Bono is still leading. Bono East is following, and then you have Greater Accra, Ashanti, and all that. So these are the regions now, and more like that place becoming a center, the center of Ghana, and we want to be able to investigate further. So far, the studies tell us what, but not how it happened. And we are anticipating that there are a few issues with migration and some other things which we need to pay attention to.
Right. We are very active on our WhatsApp is 055-5561034. HIV/AIDS cases on the rise, and our screen is active. CAF is on our screens now. CAF is going to read a few messages from you guys. CAF is on the screen now.
Good morning, Doc. Good morning, I think if the HIV campaign is not scary enough, and they should look at it again, says St. Mark, who wants a bit more fear and panic. Okay. Beautiful morning, GTV. How can one prevent this thing called HIV? And why are they spreading it, those who have the disease? It's very sad. Okay. Aaron says, apart from sex, which is the main medium of transmission, what are the other ways of getting infected with HIV since the cases keep on rising? That's Aaron from Latebiokoshi. Those are the questions we have for you so far.
All right, so apart from sex, it's mother-to-child transmission. Sex is about 85% or 80%. Mother-to-child transmission is 15%. Then these infected sharps, these manicure things, pedicure. Some of the people who go locally and then cut the barbers and all that. Transfusion, blood transfusion, infected products, but that is very rare now because of the measures we put in place. But to date, unprotected sex remains the highest. So injection drug and all that can contribute to HIV transmission.
Right. You also mentioned that some were being complacent, the numbers were rising because some people take the medication and stop. Okay. If there are these places where the patients go for the medication, isn't there a way of tracking them? Don't they have to come back after a certain period for a refill? And so if they do not come back, is that not a way to sort of track, and so we know who is doing what and what's not?
Yeah, so we are tracking them. We have a database and we follow them. But, it's a human issue. I mean, people get tired sometimes. That's why people get complained. When they are well, the assumption is that I'm fine. In fact, people were interpreting some of our results as cure. When you are suppressed, the lab may give you a result which says undetectable. It doesn't mean that you are cured.
Okay.
The virus goes to hide in some places we call the sanctuary sites. Once you stop, they come back. So people, first of all, relax and think that they are well. Some people get tired. Some people, social matters, they don't have transport to come back. Others is, distraction. They go to prayer camps and people, prophets tell them that they've been cured, they should abandon their medications. And also because they want to escape the least opportunity, they opt for it. So sometimes herbal, alternatives, then they leave it and then go for it. Then quietly they die.
Okay.
Today we don't have a cure. So everybody who promises something else is just a distraction.
Okay.
So those are some of the factors. Its factors for disengagement also includes other social factors, the discrimination, the stigma. Sometimes it's health worker attitude. Some people don't feel welcome in their facilities wherever they go, and that is why some people want to perpetually feel that we are the same with every other person, and that's why they stop. So these are some of the factors for disengagement.
Okay. Well, African countries, some African countries, I'm using Botswana. Yes, being able to reach the UN goal against HIV. Do we, as a country, is there a light at the end of the tunnel for us? Can we reach that goal?
So Eswatini, small country, 95, their prevalence is about 27%. You have to look at it holistically. So we are at 71, 95, 99, and 79, which means that we are not there yet. But in our plan and targets, all of this is linked to resources. We've decided that based on the available resources, we can get to 95 by 2025. But this will be a mirage if we don't get the resources, because you need to test more people. And there are, as I said, about 29% of Ghanaian estimated population of people living with HIV that we don't know, we've not identified. So we need to test more people. Treatment, we are putting them on treatment. It means that we have to make sure that the commodities are there so that even no new people will be added, will be catered for. The last part, which is a major issue for us, and it's because of the fact that we have had challenges with the monitoring, the laboratory equipment, the reagents, and all that. COVID-19 worsened it because of delays in shipment and all that. That is going to be a challenge, but it can change because we are 79. So we have to get to 95 in 2 years. I mean, if we double up now, we'll be able to get there.
Okay, we have some more messages on the screen. Kath, let's join in the conversation.
There was a question about why the thing is not scary, if the campaign is not, why the campaign is not scary enough. Are the medications expensive? And William wants to know, is it true that after taking the drug for a long time, like 2 or 3 years, the virus becomes undetectable and just disappears? If yes, what happens if you stop taking the drugs after testing negative?
Okay, so it can become even undetectable if you take your medications well for the first 6 months. First 6 months, even it can become undetectable. And so 1 year of taking it well will be better. All right. But when you stop it, it rebounds because it doesn't go out finally.
Right.
And current efforts is to see how we can be able to shock the ones that are hiding and kill them. And all that are part of the research going on. The first issue is, are they expensive? No, they are free. If you have health insurance, you don't have to pay. You don't have to pay
Right.
for antiretroviral. That's why I said if somebody is selling to you anywhere, there's a problem. And then there's a first question.
Can you have sex if you are HIV positive?
Yes, you can have sex, but you can have sex safely. All right, and I have
How do you do it safely?
Yeah, so I have couples who are serodiscordant. In other words, one is positive and one is negative. They have 3 kids or more. They are all negative. The kids are negative. So we teach you how to have sex to minimize the risk of transmission when you want to achieve pregnancy. But if you don't have objective of achieving pregnancy, then you should use the condom so that you protect your partner.
How would you do that if you're pregnant? What would
If you want
do? How
to
do
be
you
pregnant.
yes.
So one of the basic risk factors is when there are bruises in the vaginal mucosa. Okay, so there is an opportunity for the virus to travel.
Right.
So if the sex is well lubricated, in other words, sometimes you can help them with gels and all that, and they do it in such a way that it's not violent, and then there will not be a risk of tears and all that. The likelihood is that they can still have sex and there will be no problem. The second issue is that once the person who is positive is on treatment, there's suppression.
Okay.
So the risk of transmission is low. We've introduced a new intervention, which is pre-exposure prophylaxis.
Okay.
We will be giving it also to the partner who is negative. So the one who is positive is taken. The one who is negative is also taking it, and it minimizes the risk. So these are the methods that we are using.
Okay. So what about those who still believe that HIV is spiritual?
Yeah,
What do you say to
that
them?
is one of the most dangerous things that is happening. And once you think it's spiritual, you don't take physical appropriate measures like abstinence or being faithful or using condoms, and that will lead to transmission. Some people have even said that HIV is on a certain tree. You get HIV when you urinate behind somebody's house without permission. When a man is having sex with a woman and the woman coughs in the face of the man, that's what gives you HIV. All these myths are dangerous because people will be working in ignorance. The spiritual issue is why we are engaging faith-based organizations. The spiritual causes of HIV is not founded anywhere. The spiritual cures not founded anywhere. But I believe in the spiritual. I believe we must pray. I believe to prevent HIV. Okay, so
Right.
I think we need to address those barriers to help us. There was one question.
The scariness of the
The scariness, yes. We cannot continue to project another phase of HIV just because we want to scare people. We want to project the positive phase. We want to tell people that it's gotten better, we have treatment, but do something. All you need to do is a little more effort. But if I keep scaring you, people get used to the scare. COVID-19 got to a state, people say, no, what may, we'll fight it. You can scare people to a point, but beyond a certain level, they will not, respond.
Thank you, Doc, for coming, and thank you for educating us and cautioning us and also prompting us. HIV is on the rise, guys. Over 23,000 people have tested positive. So you abstain, you stick to one partner, or you use a condom. Dr. Stephen Eisiado is the program manager of the National STIs and HIV/AIDS Control Program, and he joined us for this discussion. The Liverpool chick Maltiti, who is still bleeding Liverpool, is coming up with sports news.